It's my honor to share with you our experience on breast ablation. Today, I will share with you the clinical application and value of MWA in the treatment of breast nodules. We know the breast has a special meaning to women. It is the symbol of women's beauty and sex appeal. And many women pay more attention to their breast. We often meet the women in our clinic. They came to ask for help. Example, doctor, I have touched a hard nodule, and I'm worried if it is a breast cancer. And I couldn't sleep all night last night. But most time, we found it just a benign tumor. Sometimes we will suggest just a regular observation. But most time, the patient want to get rid of the nodules because they are worried whether the nodule will become the carcinoma. So how to deal with the nodule? There are several ways to choose. The first may be the surgery. Although the surgery can achieve obviously result, it is difficult to be accepted by the women because it's large trauma and large postoperative incision scar, just like this, which affect the appearance. The next is the laparoscopy surgery. Most time, the laparoscopy surgery is used to breast reconstruction after breast cancer operation. Maybe the minimal invasive resection of the breast is the better way to deal with the nodules. Especially the patient has several nodules and the nodule is small. After the resection, we can see from the picture, the skin just left a little scar. Sometimes when the patient have the many nodules and the nodules blood supply is abundant, the resection may be lead to hemorrhage. At this time, we can choose another one to deal with them, just like the ablation, because most time the ablation can stop the bleeding. Some experts maybe will choose HIFU to deal with the lesion. But the lesion, the breast nodules is superficial, and maybe the HIFU is easy to bond the skin. So in my opinion, I think the ablation may be the better way to deal with the multiple nodules. In which patient can do the MWA? The Chinese expert consensus indicates the benign breast tumor diagnosed by the ultrasound and MRI and the mammography and so on. And it should be confirmed by the hollow core biopsy. And which patient cannot to do the MWA? Also, the Chinese expert consensus indicates the absolute contraindication is the severe bleeding tendency and the breast implant. And the pathological diagnosis of puncture biopsy is not clear, and so on. And the relative indication is the menstrual period and the diabetes during pregnancy, uncontrollable lactation, and so on. In the pre-operative preparation is very important. At first, we were to obtain the pathological diagnosis. We will use the 40 gauge or large amount of hollow needle and to puncture several points and to get adequate material. If the patient is taking the anticoagulants, they should stop taking this drug for at least 3 to 7 days, and it can help us to reduce the bleeding during the operation. Because the breast ablation is a new technology, maybe the patient know less about this technology, so we should do the pre-operative conversation very well, and in case help us to do the ablation more smoothly. Also, we will prepare some ultrasonic contrast agent, just like the sonoview. It is very easy to prepare and to use, but it can help us to evaluate whether the nodule is ablation completely or not. So we can ablation the nodule completely during the operation. So which anesthesia should we choose? Maybe the local anesthesia. We usually use the lidocaine. If the patient without hypertension, maybe we will add some epinephrine because it can reduce the bleeding during the ablation. But if the patient has several nodules, maybe the local anesthesia is not enough. The patient may be feel tagged. So at this time, we can choose the intravenous general anesthesia. In the intravenous general anesthesia is more comfortable. But sometimes during the ablation, the patient may be moved, which affect our ablation. At this time, the endotracheal incubation under general anesthesia is the best way, especially the patient have lots of the nodules, and the ablation time is long, and this way is more comfortable. And how to do the ablation? Let's have a look at some video. At the first, we will do the contrast enhanced. At the first, we will do the contrast enhanced. We can see that the nodule is enhanced before ablation. And then we will do the anesthesia. Maybe we'll choose the local anesthesia. We have two ways to do the local anesthesia. The first is to inject the lidocaine and not the nodule. If the patient wants to fill nodule, maybe local anesthesia, the patient will feel more comfortable. But sometimes the patient have several nodules. We will choose another way to do the local anesthesia. We will inject the lidocaine to the gap below the flesh. At this time, we didn't need to inject the lidocaine, not every nodule. And then we will do the ablation. If the nodule is very small, we can see the fixed ablation. We just need to touch the needle inside the nodule and to ablation. We will just cover the whole nodule. The ablation is okay. You can see it just cover the whole nodule. But sometimes the nodule is big. We will choose another way to ablation, the moving shoot. And the heat is evenly distributed. Sometimes the nodule is very superficial and it is very close to the skin. It is very easy to bond the skin. So we have to do something to prevent it. We will do the can you see?
Yes, we can see.
Okay. And then we will to puncture a 20 gauge long needle below the skin and to continue inject the normal cells by the assistant and to build a liquid isolation bed to apart the skin and the nodules. At this time, the ablation is more safe. Because the gas may affect our ablation, we can see the area behind the gas, we can see nothing. So we will do the order ablation. Maybe we will do from the left to the right, and from the bottom to the superficial, and from the points to the line, and from the line to the plane, and from the plane to the volume. And last, we cover the whole nodule. After ablation, we will do the contrast enhance again. You can see the nodule is not enhanced again. So the ablation is okay. So the nodule is completely ablated. The next, we will show some cases. This is the nodules. It is enhanced for ablation, and we'll to do the biopsy and to obtain the isolated diagnosis. If it is a benign breast tumor, we will do the ablation, and we'll do the fix the needle first. This one is the ablation needle, and this is the long needle to inject the normal cell. We will to monitor the two needles during ablation and to ablation. After ablation, you can see from the contrast enhanced, the nodule is destroyed. Also indicated by the MRI 1 month later, and the effect is very good. This is another one. You can see the nodules. And we also do the biopsy and then to ablation. After inject the normal cell, we can see that the tissue is swelling and can apart the skin and the nodule. After ablation, you can see from the contrast enhanced. Also, the nodule didn't enhance again. Also indicated by the MRI 1 month later. And the effect is also very good. Sometimes we'll make the cyst. Like this patient have lots of the cyst. At this time, the patient may be touch a hard nodule and feel very uncomfortable. So they want to deal with the cyst. We also can do the biopsy and to do the ablation. After ablation, we can see that the cyst is cured. Someone may be very interested in its safety. Also, like other technology, the ablation maybe make the complication, just like the pain, the ablation area swelling, the nodule, but most of this is slight and didn't need to deal with them. Sometimes we will make the hemorrhoids, the hematoma, fever, and memory duct injury, skin bone, muscle injury, and so on. But most of this can be prevented. To prevent the complication, sometimes we will do the obstetrical way. The first is to build a liquid isolation bed. We will use the 20 gauge long needle, connect the long tube, and to inject the normal cell. We will puncture the nodule, puncture the needle below the skin in front of the ablation needle, so we can to monitor the two needles together. Sometimes the nodule is very close to the skin and very close to the deep fissure. At this time, we maybe will reduce the power to ablation. Also, we can move the needle tip. Just like this, we can press the needle tip down, and the nodule is far from the skin. At this time, maybe we will fly up the needle tip, and the needle is far from the deep fissure. Sometimes we will do the fixation ablation. Maybe some folks are not good at moving soup, also can choose the fixation. Maybe we'll use a single needle to single point to ablation if the nodule is very small. The nodule is big. Sometimes we will use a single needle to several points to ablation. And the nodule is very big. Sometimes we also can choose a double needle to several points to ablation. But if the nodule is very big, we will choose the moving shoot ablation because the heat inside the nodule is evenly distributed. Because the gas will affect our ablation, so we have to do the orderly ablation, maybe from the left to the right, from the bottom to the superficial, and from the points to the line, from the lines to the plane, and from the plane to the volume, and the glass to cover the whole nodules. Sometimes we will make the large cyst. At this time, we just to puncture inside the large cyst to ablation is very slowly. At this time, we can take out the liquid first, and to ablation it may be quick. And sometimes the small cyst we just to puncture inside the cyst, and to ablation is okay. Sometimes the skin and the tissue of breast is hard to puncture. At this time, we will do something to prevent the needle to be broken. Maybe we will puncture the skin with a 20 gauge needle. And during the ablation, we have to monitor the needle very clearly. If we cannot see the needle tip, we didn't move the needle and didn't ablation. After ablation, we will do something to reduce the temperature to protect the skin. Maybe the wet alcohol gauze covered the ablation area. Maybe the local ice pack to reduce the temperature, and to do other things to protect the patient. Maybe the hemostatic treatment and so on. We will use the contrast enhanced MRI to evaluate the effect of the ablation. Sometimes after ablation, we can see the nodule is absorbed. From our follow-up cases, we found after ablation, the patient may be touched a more hard nodules because the nodule is ablated. And the patient cannot touch the nodules again in 3 to 9 months after ablation. And most of the patients absorb very fast. But sometimes we will make some patients absorb it very slowly, but the patient is less. So we think the ultrasound-guided percutaneous breast microwave ablation is an ultra-micro-invasive, effective, aesthetic, and recommended treatment for benign breast tumor. Here's my report. Thank you for your listening.